마지막으로 네 번째 발제자분은 영국 월드비전의 그 시니어 헬스 어드바이저로 계시는 이지은 전문가 분이십니다. 이지은 전문가님은 현재 영국 월드비전에서 근 거의 6년간 근무를 하시면서 아프가니스탄, 소말리아 그리고 시리아 같은 프레자일 국가들에서 국제보건 프로젝트를 하고 계시고요. 현재 IV에서 컨설턴트로도 활동을 하고 계십니다. 이지은 전문가님께서는 오늘 Principles and Practices of Health System Strengthening in Fragile Setting, conceptual reflections and operational perspective 라는 주제로 발표를 해주시겠습니다. 한국 분이시긴 하지만 영어가 더 편하다고 하셔가지고 오늘 영어로 발표를 해주시겠습니다.
네, 안녕하세요. 이지은입니다. 영어가 더 편해서가 아니라 해당 업무랑 연구를 영어로 진행했기 때문에 편의성을 위해서 제가 영어로 발표를 하도록 하겠습니다. 오늘 이렇게 유일한 인퍼슨 발표자인 거 영광이고요. 네, 오늘 말씀드릴 내용은 저희가 영국에서 영국 베이스드인 학회 그리고 NGO들이 함께 진행한 연구를 이야기를 드릴 텐데 아무래도 이 주제 자체도 많이 좀 생소하신 분들이 있을 것 같아서 여러 가지 백그라운드 관련된 내용과 함께 연구 내용 말씀드리도록 하겠습니다. 네, 자꾸 한국말로 하고 싶네요, 저도. 네, 영어로 하겠습니다. So today's presentation is composed of two different parts. So first of all, I will be speaking about what health system strengthening means, as well as what fragile and conflict-affected setting means, and why health system strengthening in the fragile context is important. Secondly, as the main part of the presentation, I will be presenting findings of the UK-based academia NGOs' collective research on health system strengthening in the fragile conflict-affected settings. In order to shorten the time of the presentation, I'll be referring to health system strengthening as HSS and fragile and conflict-affected settings as FCAS. So to define the fragile and conflict-affected settings, those are settings where there are multiple complex risks that are composed of two different underlying causes. One, the actual risks and root causes such as extreme poverty, conflict, violence, disasters, epidemics, all the things that we know of as shocks. However, when it's coupled with and combined with insufficient coping capacity of the state, system, and/or communities to manage and absorb and mitigate those risks, we would consider these settings, states, and countries as fragile context. These are FY24 list of FCAS. So you can see that it's fragile and conflict-affected situations. Although it's listed as countries, there are different pockets within countries that have different levels of fragility. And you can also see that there are countries that are affected by conflict, but there are others that are affected by institutional and social fragility. This list is revised every year based on a few different indicators, including conflict-related mortality figures, as well as the capacity of the states to manage risks. And why is it then important to focus on the FCAS? Approximately 1.8 billion people currently live in the FCAS, and this composes of 23% of the world's population and represents over 75% of the number of people living in extreme poverty around the world. And it's also supported by stark demographics, as this number is expected to increase to more than 2.2 billion as we experience growing violence, inequality, and persisting conflicts, as well as displacement and different types of shocks, such as epidemics and climate-related insecurities. And in 2018, the under 5 mortality rate in the FCAS was almost twice the global average. And the maternal mortality rate was 4 times higher than in the non-fragile context. So when we talk about equity, And before we even talk about quality, those are contexts where there are severe issues in access to basic healthcare services. I would now want to talk about the health system strengthening. I think we're all very well versed with the 6 building blocks of the health systems defined by WHO. Those are governance, information, financing, service delivery, human resources, medicines, and technologies. And when we talk about health system strengthening, we aim to we aim for those 4 different aspects. So first, we would like to make sure that the scope of the health system strengthening has effects cutting across building blocks and tackling more than 1 diseases. And then in terms of the scale, for it to have a national reach, cutting across more than 1 level of the system, which basically means not only in primary healthcare systems, but to tertiary and multiple levels of the health systems. And then in terms of sustainability, we aim for it to have a sustained impact over time and addressing more of a systematic blockages and having impact on outcomes, equity, financial risk protection, responsiveness. And that, although these impacts may happen over time, these longer-term resilience building approach is what we call the health system strengthening. So I will, in the later part of the presentation, I will mention what we don't consider as health system strengthening when often we think it is. I just wanted to get a bit more personal about this issue. I once visited Burundi, and I want to illustrate the challenges that we face in such protracted crisis, fragile settings in terms of healthcare provision. So as many of you may know, Burundi is a landlocked country in East Africa, surrounded by different countries like Rwanda, DRC, with beautiful landscape such as the Lake Tanganyika and stunning hills. However, it has faced multiple conflicts, displacements over the last 2 decades, resulting in 2017 having only 500 doctors operating across the whole nation. And at one of the, I think I remember it's 2018, where half the population of the whole country suffered of malaria, with 1,800 deaths only in that specific year. So that you can see how the conflict and insecurity has resulted in fragile health systems as well. This is the Burundian twin that I had met in 2012, which has actually led me to study public health and get into global health. And basically, a twin of a displaced family, a refugee family, was in a hospital when I met them. They had become severely malnourished and anemic because mom, who was the caretaker of the twin while the dad was in another country, Tanzania, working just, earning day-to-day income, doing manual labor. And when mom fell sick and unconscious because of malaria, the twins were left without any support, any feeding for quite some time. And it was quite devastating because one of the twins died, as there was no needle for blood transfusion in the whole of Burundi at that moment, which was really hard to believe, but it was true. So you can see how multiple levels of fragility, especially in the health systems as well as in the country, results in such losses. So it was really hard to hear the father saying, just very accepting of the fact that things happen in life and there's really nothing to do about it, when actually those deaths were very much preventable. It reveals issues in increased disease burden with reduced access to health services, disruptive community health systems, which would have picked up the twins before they became very fatal, and health facilities non-functioning or very weak, disruptive supply chains, lack of essential medicines, and no or low level of financing for health services, corruption, and weak governance. So then just to rationalize why health system strengthening approach is important in the fragile context. Just want to say that it's really important to build a health system that's resilient to shocks and stressors. We've witnessed this during COVID-19 pandemic, where we saw, even in the high-income countries, the health system wasn't resilient enough to be able to respond to increased amount of shocks, as well as the different the augmented level of service needs, but even more so in such FCAS settings where there are cyclical shocks. We call it the protracted crisis setting, where there are multiple shocks occurring cyclically, so it just keeps returning. Hence, there is much more need for it to be stronger and resilient. Finally, to the second part of the presentation, where I will be talking about the qualitative research, qualitative study which we have conducted. It's titled Principles and Practices of Health System Strengthening in Fragile Contexts. And I just want to give credit to Maria Burton, who is my colleague academic in the academia, who's come up with this presentation. The reason why we wanted to focus on the practices along with the principles was because there is now these middle actors, intermediary actors. Many a times they're NGOs that are working in humanitarian and development and peace-building nexus, across different settings where there are fragility. And in many of those contexts, NGOs are actually the primary service deliverer of essential health services. And however, it always seemed like, we all recognize that it's important to build up systems instead of just keep providing emergency responses and emergency services. But there seemed to be an issue of one, not having enough empirical evidence on how to do health system strengthening work in such a fragile context. And also there are different parameters set by donors that make it difficult for us to do a longer term systems building work. And also really just practical challenges of dealing with day-to-day work and considering a more of a longer term approach and risk management as well. There are some efforts taken by NGOs at the moment, such as the one of my own organizations. So this is just a summary of one part of what we call a fragile context health and nutrition programming approach. Here you can see that there are 3 different dials: survive, adapt, and thrive. This describes different situations where we encounter in the FCAS where we need to focus really on ensuring survival of the population that we work for. So here you can see an example of service delivery as really delivering clinical primary healthcare services to the vulnerable populations. If we need to do it through mobile clinics or temporary facilities, let it be the primary focus is that we reach those people with essential services. But then when we when we actually get into a stage where there is a little bit more stability, we would consider this adapt and thrive stages, where we would stop doing direct implementation and start working with the MOH, which is Ministry of Health in the respective country, to build their capacity and to really empower the civil society to hand in hand work with the government to improve the services, access to services and qualities. This is an example of how this has translated in one of our programs. This is a 20 years work in Somalia, funded by Global Fund TB program. So this is essentially a TB program. And what started as a vertical program, which means we've only done TB work for TB patients, nothing else. It has now translated into integrated service, which means we are part. The TB program is part of a primary healthcare facility service, we've also strengthened community-based care. And other achievements include that we were able to navigate the politics, operationalizing a stable local governing system. There are actually 3 different governments in Somalia: Somaliland, Puntland, and Somalia. And because of that, it's really, really hard for any actors to come into Somalia and have a coordinated approach in doing their work. However, we were able to at least gather together any donors, any stakeholders, NGOs, MOH that does work on TB to be able to reduce duplication and to improve integrity. We've also used some of the diagnostics capacity of TB during COVID-19 to transfer into COVID-19 diagnosis. So this is just the last bit of why this research came about. In the UK, we work with the government partner called FCDO, which is equivalent to KOICA in Korea. And they have a very strong focus on health system strengthening across all sectors. And NGOs that have had questions about how best to navigate a longer-term resilience-building work in FCAS has actually come together with the FCDO to have a roundtable to discuss what are some of the collaborative policy recommendations we can provide to the government as well as to other governments that are doing global health work in FCAS. And so we've come up with a brief that talks about the need and rationale, main challenges, evidence, and recommendations, policy recommendations, which has been actually integrated into many of the CSO's collective policy asks, and is in the verge of being part of the new global health strategy of the UK government, if it happens, although there are some political implications. So this is the background of the research itself. I think this just summarizes what I've been talking about. While health systems strengthening is a term commonly used in global health, and it's seen as essential, it remains an elusive concept, and it's much debated about how to define and how to measure progress towards HSS. I think I had a conversation with Professor Lee a few weeks ago about this as well. How do we then measure a good health system strengthening intervention? And that is more so in the FCAS, where there is weak governance and fragmented response. Hence, we wanted to really focus on teasing out the operational and experiential perspectives. Since this is a study, we have had our definitions and distinctions on what to include and what not to include. So we have seen health system strengthening as an intervention done by NGOs. And we have taken out anything that is of health system support, which basically means simple, short-term inputs into different building blocks of health systems, such as short-term training or providing of ambulances, providing of medicines in a short-term manner. So we have not considered that as a health system strengthening effort. We've also differentiated between health systems resilience and recovery with health system strengthening, because health system resilience and recovery covers different aspects of what we do within the health systems to ensure resilience and recovery. But what we really aim to do is to talk about a wider health system strengthening as a more of a longer term systems, changing the dynamics within the systems, having governance established, and really having letting the health systems have a genuine innate capacity to be able to operate its own systems. It was a qualitative study, as I've mentioned before. We've had two different methodology in terms of data collection. First, we've conducted 25 expert interviews and 17 photo elicitation, which basically means that there were NGOs in 17. There were actually 17 NGOs in 11 countries. There were 11 countries and 8 NGOs and 17 entries in total, where there were photos taken by these, really frontline workers about what they think is health system strengthening in their context. And then we've had interviews with them to tease out more in detail about what they meant to capture in those photos. Major limitation is that it did not capture the Ministry of Health perspectives, which may actually give us a very complete view or a very different story about what they're facing in the FCAS. But this is bound to be the next stage of our research. We've analyzed and synthesized we've analyzed this and synthesized both the contents of the interviews, the photo elicitations, and the interviews that were conducted with the participants of the photo elicitation. So this is, just the list of NGOs in case you're curious. Right. Findings were presented two different main areas, which is challenges and entry points and promising health system strengthening approaches. And there were 4 different themes that arised from our synthesis of data. I'll skim through them one by one. So first was fragility, insecurity, humanitarian priorities. Very grand title, but what we try to capture in this theme is that there are innate challenges in those settings due to insecurity, lack of access, missing basic hardware elements of the health system, such as the destroyed infrastructure. As you see on the left here, you can see the state of the hospital, where basic hardware does not exist or is very damaged. There's collapsed supply chain and information systems, shortage of health workers and drugs, which basically means that all of the systems building blocks are challenged in this setting. So this is the baseline that we need to consider. On top of that, there's also the general uncertainty that makes planning, including a longer-term health system strengthening approach, very difficult because of cyclical shocks and the nature of the fact that there's no governance. So often, priority is considered to be saving lives and focusing on service delivery and health system support at most. So and also because humanitarian workers work in a very different modalities with development workers, and they're very used to simply providing what the population needs at that point in time and then leaving the country. So it's very hard to consider a longer term view. However, many have also said that there is a potential to leverage the humanitarian phase for health system strengthening. So there were hopeful notes that said that emergencies are cyclical, like I said, in a setting, for example, in Eastern DRC, and we should be able to capitalize on the emergency response for HSS, mostly because that's the type of funding they usually get. And there are also some people that said that humanitarian actors, who are usually NGOs, are not mandated to do HSS, but should at least do no harm. I think I'll mention in the later slides, but there is a huge divide between different actors that operate in such protracted crisis settings. Because in the past, it was only the humanitarian actors that operated in such contexts, such as, as you may know, Hanbia 팀장님 from ages ago, who I've worked with actually, we often think that they're the only ones that, just, go in when there's a crisis, provide support and come out. But because nowadays the crises are protracted and longer term, there are many different actors, such as development actors, also coming in and trying to do a longer term work. But because of the modalities that the humanitarian workers have been operating for a long time, it's really hard to change or integrate the way that they work. So you can already see that there are very different views about whether or not to do health system strengthening work in the fragile context. And this really comes out in this quote, that wretched nexus stuff. So we have a terminology called humanitarian development peace-building nexus, because they are very different segregated areas and actors that work in this space. People have been talking about how all of these actors should come together into one nexus. However, people are saying that wretched nexus stuff, it exists, but then does it actually work? People say that nexus is positive area, it opens up a conversation, but in practice it is difficult to harmonize and operationalize. So operationalizing the nexus should start with financing, as there are different actors that have different donors, and it's really hard for them to open up and be transparent about the activities as well as the fundings. And like I've mentioned multiple times, governance is a big issue. As there is lack of political peace and weak governance, it makes HSS more difficult, as governments are often weak, absent, or multiple, or not legitimate, which means that it's not recognized by the international community. So, because health system strengthening somewhat assumes the existence of a single national government and a public health system as a precondition, people are questioning, can a health system strengthening be done without it? And how can we actually foster local leadership and governance that result in a sustainable intervention? You can see how governance results in different results when we deliver care services. So, for example, this is ambulance that's been provided that's been left without being used because of lack of governance, whereas this one it's being very well maintained with good governance. So sustainability is a core element of health system strengthening, but interventions are often planned and implemented in not sustainable. And so there is a trade-off between getting work done directly and or working through the government, which is much more complex and time-consuming. There are approaches that have been highlighted by the key informants who talked about NGOs' role in letting government and public health authorities to lead, or at least increasing their visibility. So this picture is an example from Somalia, where an organization that conducted community engagement meetings to gain feedback with the Ministry of Health, which increased the visibility of the government in Somalia, because there are different NGOs running different health facilities. There's actually no coordination done by the Ministry of Health. Hence, this NGO, what it aimed to do is to actually tell the community that there is a government that is operating, that is coordinating, that is overseeing all the work that the NGOs are doing. Another entry point is the local health authorities, which is really the primary healthcare level or district level authorities, to work with them if it's really hard to have a national level government to engage, than to engage them, or even non-public actors such as community actors and civil society, faith-based organizations and providers and private sectors, because often there are immense issues of accessibility to remotest parts where they are the most vulnerable, and national government often does not have ideas, data, and access to those regions. So it was considered best for NGOs to actually work with those local authorities. The next topic is the aid architecture, which is actually a very important topic to tackle. I think there will be some discussions about government's role, and I think this is a very tough call, because it's inevitably many of the donors would have different mandates, agendas, and interests. Not only the donors, but also, so humanitarian development funders, global health initiatives, which basically means Global Fund, Gavi, and these initiatives, and according to different departments and NGOs, everybody comes with different sets of activities, timelines, funding, and coordination approaches, as well as different understanding of what health system strengthening means. So this results in a fragmented short-term funding, focusing on service delivery or disease-specific health system support, and focusing only on measurable and countable outputs and outcomes, which is often expressed in lives saved. Some of the promising approaches to change the aid architecture is to focus on primary healthcare and integrated healthcare, which was actually voiced out by a lot of frontline workers, saying that the different donors are doing vertical programs. Imagine we put them together and do one comprehensive program. The answer is integration. And you would now sit here and think about, why is that an issue? But it is a huge issue, as for example, one of the major donors in FCAS setting is Global Fund, and as you can see, they cover TB, malaria, HIV, and often, it pans out as a very vertical program that does not care for any of the other essential health needs. And so moving away from service delivery and inputs, and allowing space and funding for a more flexible HSS activities was called by many of the participants. So yeah, this is essentially intentional, flexible approaches to health system strengthening programming that allows experimentation and adaptation and tailoring to context and fostering a culture of learning. So there are some projects, such as the ones that's mentioned here, but also a few that's been funded by the UK government through World Vision in Afghanistan, that that really gives this room of flexibility and being more intentional in giving longer-term funding, and to have to allow the NGOs to change their design according to change in situations and the shocks, new shocks, and cyclical risks that they encounter. And coordination also is important when it comes to improving the aid structure, issues with the aid structure. So coordination, since there is no government that is able to coordinate different NGOs and different funders to come up with one single package that delivers all the essential services to the communities. It's really important now for the development partners, such as NGOs and donors, to have a more decisive role to combine and making sure that there's no duplication of resources when there's already scarcity of resources. So the last bit is about then, what is the role of NGOs? So NGOs are not better placed for health system strengthening, and taking the strategic view was the view of the key informant within the research, and they've actually voiced out that it is necessary for for others to provide a supportive structure and set of clear incentives for funders to be able to facilitate and do HSS. So I think it's just the matter of all thinking that this is important, but NGOs being restricted by the way the funding is given and by the way that they need to report to the funders, but also the funders are restricted because they face the issue of risk management. So this has actually been raised as one of the issues to resolve before we go on to the next stage and talking about the health system strengthening. So what can we learn? I think it was quite interesting to have the views of the implementing actors, which were the middle level of this ecosystem. So between the funders and the in-country actors such as communities and the Ministry of Health. And inevitably, the findings highlight challenges, which is not unknown. But I think it was really helpful to hear and validate those challenges from the ones that are actually carrying out the work. But also we've teased out a few entry points and promising approaches and the blind spots in policy and practice that have not been systematically discussed and even less so addressed. So as the next steps, we will be carrying out more data collection, engaging the Ministry of Health in those FCAS countries. And we will also be coming up with policy recommendations for the UK government, and we will be working with the UK government to tease out how best to collaborate on this issue between the implementers and the funders to create a standard of benchmark so that other countries can also replicate and pursue a more longer term work even in the fragile context. Thank you for listening, and if there's any more questions, I'm available to take questions. I'll be in the front of the room. Thank you very much. 감사합니다.